So, hello everyone, my name is Jennifer Lasablaus, IBS MLS 3C student together with Naimi Tabudlong, which is also a BS MLS 3C student. So in this video, we will be tackling all about the cerebrospinal fluid or the CSF, which is part 3 of the lesson, which is all about the other body fluids, and it's chapter 9 from it. Sa topic. So, first of all, let us know first what is a CSF. Since our topic will be all about CSF, so we should discuss a brief discussion on what is CSF. So, the cerebrospinal fluid is a clear fluid that surrounds our brain and our spinal cord, which produce the brain ventricles mainly in the cortex or the CSF, which provide the crucial function, which is also it provide as a protective cushion that absorb the shocks and reducing the brain's effective weight. CSF also facilitate nutrient transport to the brain. It also remove waste and help regulate the temperature of the brain. It also continuous circulation, maintaining unstable chemical. Any alteration in CSF composition or flow may indicate neurological issues. So, that's why bawal ang blood sa ato ang brain because it could cause indicate some neurological issue. And by this, maigo ang ato ang any like kanang voluntary movement or speech and so on and so forth. So, CSF also produce a mechanical barrier to the cushion and to the brain and the spinal cord against the traumas. So, let's proceed. So formation and physiology of the CSF. So, this is considered as the third major body fluid. It is also a clear and colorless fluid found in the brain and its spinal cord and all vertebrates of or the CNS. CSF also gives protection for the external forces like trauma found between the arachnoid matter and the pia matter or the subarachnoid space. So, always remember that the layer of the membrane that gives protection to the brain seen as an outer covering of our brain. So, as you can see in here, in the picture A or the upper picture, that is the layer of the meninges in the brain, and the B is the layer of the meninges in the spinal cord. So, always remember that dili mawala ang tulo sa ato ang CSF or sa brain natin and sa ato ang spinal cord, which is the three: the dura mater, the arachnoid mater, and the pia mater. So in dura mater, this is where the lines in the skull in the vertebral canal. It also beneath the skull, which is also the outermost layer, the thickest layer, and it's also called as the hard matter. Next, we have the arachnoid matter, which is the inner membrane. Next we have the pia mater, which is the gentle matter. This is a thin membrane layer in the surface of the brain and the spinal cord, which is the most thinnest or the thinnest layer, which is, as you can see in the photo, makita na ninyo na ang pia mater is mo siya ang pinakamipis. And same goes by with the sa atong spinal cord nga ang pia mater ang pinaka thin. So, next we have formation and physiology. CSF is produced in the coral plexus of the two lumbar ventricles and the third and the fourth ventricles. In adults, it usually give In adults, approximately 20 ml of fluid is produced every hour. The fluid flows through the subchord space located between the arachnoid and the pia mater to maintain of 90 to 150 ml in adults and 10 to 60 ml in the neonates. And the circulation fluid is reabsorbed back to the blood capillaries in the arachnoid, and granulation or delay at a rate equal to its production. The cell of arachnoid granulation acts as one-way valves that respond to the pressure within the central nervous system or the CNS to prevent the reflux of the fluid. So, we have the specimen collection and the handling. So, CSF is routinely collected by the lumbar puncture between the third and the fourth lumbar of the vertebra, which is sa kanang sa spinal cord. Makita na ito, maano man na ito na in our ma-explain pa dyan na sa in our future discussion in regards with this. Pero diri siya sa spinal cord, which is kanang needle nga iturok siya sa ikod, like sa spinal cord, then isulod nila gently and mag-suction sila, and mo na siya ang CSF. Kanang makita na to na puti na part. So it is also yun yung mga circular cannulas or shunts. Next, we have the specimen are collected in 3 stereotubes, which are labeled from tube 1, tube 2, tube 3, in order to which or what they have been withdrawn. So, in tube 1, it is used for chemical and serological tests because these tests are least affected by the blood or the bacteria introduced as a result of the TAP procedure. Next, we have the tube 2 that is usually designated for the microbiology laboratory or microbial examination. For again, magbalik tayo sa tube 1. Mostly the tube 1 is for chemistry and immunology study. And for tube 3, this is used for cell count because it is the least likely contain cell introduced by the spinal tap. Or usually, ang tube 3 is ginagamit na to siya for cell count and for the cell count or differential count. So, next is natay additional na test or na tube for that, which is for cytological investigation of if there is a malignancy that has been suspected. So, for better exclusion of the skin contamination for additional serological tests. So, next is that always remember that for the hematology tubes is always refrigerated. Microbiology tubes should be at the room temperature, and for the chemistry and serology tubes should be frozen. And all samples should be examined within 1 hour to minimize the cellular degradation. So, always remember to have also the precaution kay measurement of the intracranial pressure before collection. Always remember to monitor the intracranial pressure for 24 hours to know if after the collection the patient can maintain the pressure. That's why we are using like what do we call this one? Like we are using good anesthesia para mag-get food sa kanang CSF kay it's very sakit jud, especially para sa mga baby nga very low ang ilahang or pain tolerant. So it should be at least 5 to 15 mmHg and 20 to 30 for mild intracranial hypertension if no CSF collection. And always remember to have a careful technique to prevent infection or neurological tissue damage. And the details should be provided about this is that the limited of 20 ml highlights the need of the precision. Ang kailangan lang na to. So, next is the appearance. The appearance of this is usually na kanang normally crystal CSF and can be provided by diagnostic information examination of the fluid. Of the fluid occur in the first at the bedside, and it is also included on the laboratory report. The major terminology used for CSF is include the crystal clear, the cloudy, the turbid, milky, centrochromic, and the hemolyzed. And this is the initial appearance. The appearance of normally crystal clear CSF can provide valuable diagnostic information. The major terminology used for CSF is to describe like this. Okay? Always remember that it has crystal clear. Same lang siya sa urine, nga na siya crystal clear, cloudy, turbid, milky, centrochromic, hemolyzed, or bloody. So, as you can see in here, there are 4 tubes na sa ato ang which is a clear. The right is normal. Next, we have the centrochromic, hemolyzed, and cloudy. Next, we have this table, which is a clinical significance of the CSF appearance. So, always remember nga if crystal clear, hazy, turbid, milky, or cloudy, ang makakause ani are WBCs, microorganism, or proteins. The major significance could be abnormal, meninges, and disorder affecting the blood-brain barrier, and protein IgGN with the CNS. So, just read this and just pause the video and since you can this like basahon na lang inyo. Next, we have the traumatic collection or the TAP. So for the traumatic TAP, these are the grossly bloody CSF that can indicate of intracranial hemorrhage, but it may also be due to the puncture of a blood vessels during the spinal cord procedures. So there are 3, which is the uneven blood distribution, clot formation, and the centrochromic supertan. So so first of all, the uneven blood distribution is the blood from a cerebral hemorrhage will be evenly distributed throughout the 3 CSF specimen tubes, whereas a traumatic TAP will leave the heaviest concentration blood in the tube 1 and gradually diminishing the amount of tube 2 and the tube 3. So performing the RBC count on the 3 tubes measure decreasing or constant blood that is not always reliable. So streak of blood may also be seen in the specimen acquired the following traumatic procedures. So dili siya tanan na because of na siya blood kay na murag ka ng due to the trauma sa brain. However, makakos po daw ang mga procedures which is marag mamali ug get ang specimen. Next, we have the clot formation. So, the clot formation is a fluid from the traumatic TAP may form clots and allowing to introduce the plasma and fibrinogen into the specimen. Bloody CSF caused intracranial hemorrhage does not contain enough fibrinogen to clot. So next we have the xanthochromic supertantes. The RBC must usually remain in the CSF approximately 2 hours before the noticeable hemolysis begin. Therefore, a xanthochromic supertant may be also um, may be also could result blood that has been present for a longer introduced by the traumatic shock. So always remember that care should be always taken. However, consider this examination in conjunction to those previously discussed because a very recent hemorrhage would produce a clear supertant. Always remember that. And in recent and in introduction of serum and protein from traumatic tap could be also caused by the fluids to appear in xanthochromic. To examine a bloody fluid for the presence of xanthochromic, the fluid should be centrifuged in a microhematocrit tube and a supertant examined against the white background. So, and next we have the cell count, which is usually or routinely performed in the CSF specimen of the leukocyte or the WBC. So remember in our hematology class that we have performed the Neubauer counting chamber, which is kinda hard for us since it's our first time and kailangan ng sipag at syaga during that. So next, we have the RBC count are usually determined by when a traumatic tap has occurred and correction of leukocyte or protein is desired. Can be calculated by performing a total cell count and a WBC count by subtracting the WBC count from the total count. WBC or particularly the granulocyte and RBC begins to lyse within the 1 hour, and the 40% of the leukocyte disintegrates after the 2 hours. Always remember that the normal adult CSF contains 0 to 5 WBC UL, and for children as many as 30 mononuclear cell per UL, and specimen contains up to 200 WBC or 400 RBC per UL may be appear clear. So always remember that when you are counting a Neubauer is from like this, like paana like a zigzag or like a marag snake and ladder, pero from right to left like paana mura siyag maze. So calculating the CSF count, the formula can be used for both. So this is the formula, and always remember that the number of cell times dilution, number of cell times the volume of the square is equals to cells per UL. So example of this is the number of cell times dilution times 1 UL, then time U1 UL for the volumes, and third times 0.1 times 10, which is the volume per square, is equals to your cell or cell per UL. So always remember that all diluents should be checked bi-weekly for contamination by examining them in a counter chamber under a 400 magnification. Contaminated diluent should be discarded and a new solution is prepared. If non-disposable counting chamber are used, they must be soaked in a bacterial solution for at least 15 minutes, then thoroughly rinse it with water and cleanse it with isopropyl after each use. So, next we have the differential count, which will be tackled by Miss Naimi.
Good day, my name is Naimi Sita Badlang and I am going to continue the reporting. So, differential count on CSF. So, Identifying the types of the cells that is present in the CSF is a valuable diagnostic aid. The differential count should be performed on a stain smear and not from the cells in the counting chamber, because the poor visualization of the cells as they appear in the counting chamber has led to the laboratory practice reporting only the percentage of mononuclear and polynuclear cell present. And this can result in the overlooking of abnormal cells present, and this with the considerable diagnostic importance. To ensure the maximum number of cells are available for examination, the specimen should be concentrated prior to the preparation of the smear. So, there are different methods that can be utilized for a specimen concentration, which is the sedimentation, filtration, centrifugation, and cytocentrifugation. So, the sediment and filtration are not routinely used in the clinical laboratory, although they do produce less cellular distortion, because most laboratories do not have a cytocentrifugation concentrate specimen with routine centrifugation. So always remember that when the differential count is performed, 100 cells should be counted, classified, and reported in terms of percentage. If the cell is low and finding 100 cells is not possible, report only the number of the cells type C. So the next slide would be the cytocentrifugation. So this cutaway drawing which illustrates that at the left the inner load position which shows the sample's chamber assembly in a tilted back position so that the sample is not absorbed by the filter card during spinning, centrifugal, or stills the assembly upright and forces the sample to flow toward the microscope side. Next would be the table of the cytocentrifugation recovery chart, as where you can see the number of white blood cell counted in chamber and number of cells on the centrifuge site. The CSF cellular constituents. So the CSF cellular constituents, which is the cell is found on the normal CSF and primarily the lymphocytes and the monocyte. So adults only have a predominance of lymphocytes to monocyte, which is 70-30, whereas the ratio is essentially reversed in children. So 5 improved concentration methods are also showing occasional neutrophils in CSF. So the presence of increased numbers of these normal cells, which is termed pleocytosis, is considered abnormal. So as is the finding of immature leukocytes, eosinophils, plasma cells, and macrophage, increased tissue cells, and malignant cells. So, when the pleocytosis involves neutrophils, lymphocytes, or monocytes is present, so that CSF is differential count is most frequently associated with this role in providing diagnostic information about the type of microorganism that is causing an infection of the meninges or meningitis. The neutrophils. So, in addition to bacterial meningitis, the increased neutrophils are also seen in the early stages 1 to 2 days of viral fungal tubular parasitic meningitis, because the neutrophils may also contain cytoplasmic vacuoles following the cytocentrifugation. And the neutrophils are pycnotic nuclei, indicates degenerating cells that may resemble nucleated red blood cells but usually have multiple nuclei. So, when a single nucleus is present, they can appear similar to nucleated red blood cells, as are seen as a result of bone marrow contamination during the spinal tap. Next would be the lymphocytes and the monocyte. So, the lymphocyte and monocyte is a common cases of viral tubercular and fungal meningitis. So, reactive lymphocytes containing increased dark blue cytoplasm and clump chromatin and are frequently present during viral infections. in conjunction with normal cells. The increased lymphocytes are seen in cases of both asymptomatic HIV infection and AIDS because a moderately elevated white blood cell count that is less than 500 white blood cells per microliter with increased normal and reactive lymphocytes and plasma cells may be indicative of multiple sclerosis or other degenerative neurologic disorder. Next slide would be eosinophils. So, eosinophils is an increased eosinophils that are seen in the CSF in association with parasitic infection, fungal infection, which is primarily Coccidioides immitis, and introduction of foreign materials, including the medication and shunts, into the CNS. Next would be the macrophage. So, the macrophage, the purpose of this in the CSF is to remove the cellular debris and foreign objects such as the red blood cells. So, the macrophage appears within 2 to 4 hours after the red blood cells enter the CSF and are frequently seen following repeated taps. So they tend to have more cytoplasm than monocyte in the peripheral blood. So the finding of increased macrophage is indicative of previous hemorrhage because the further degeneration of the phagocytes red blood cells results in the appearance of dark blue or black iron containing hemosiderin granules. And the yellow hematoidin crystal represent further degeneration. So they are iron-free, consisting of hemoglobin and unconjugated bilirubin. Next slide would be the non-pathologically significant cell. So they are the most frequently seen in diagnostic procedures such as the pneumocephalography and in fluid obtained from ventricular taps or during neurosurgery. So the cells often appear in clusters that can be distinguished from malignant cells by their uniform appearance. So there are choroidal cells, epidermal cells, and the spindle-shaped cells. So the choroidal cells are from the epithelial lining of the choroid plexus, so they are seen singularly and in clumps. So the nuclei are usually absent, as what you can see, and have a uniform appearance. So next would be the epidermal cells that are from the lining of the ventricles and the nuclear so they have less defined cell membranes and are frequently seen in clusters, nucleoli, and often present. Next would be the spindle-shaped cells. These represent lining cells from the arachnoid, so they are usually seen in clusters and may be seen with systemic malignancies. The malignant cells of hematologic origin. So the lymphoblast, myeloblast, and the monoblast in the CSF are frequently seen as a serious complication of acute leukemias rather. So the nuclei are more prominent than in blood smears, and the lymphoma cells are also seen in the CSF indicative and indicate dissemination from the lymphoid tissue. So they resemble large and small lymphocytes and usually appear in cluster of large, small, or mixed cells based on the classification of the lymphoma. So nuclei may appear cleft and prominent in the nuclear present. Next slide would be the malignant cells of non-hematologic origin. So the metastatic carcinoma cells are non-hematologic origin, which are primarily from lung, breast, renal, and gastrointestinal malignancies. So the cells from primary CNS tumors include astrocytomas and retinoblastomas and medulloblastomas, which is fusing of cell walls and nuclear irregularities. And hyperchromatic nuclei are seen in cluster of malignant cells. The slides containing abnormal cells must be referred to pathology. Next slide would be the chemistry test. First is the cerebrospinal protein. So the cerebrospinal protein is the most frequently performed chemical test on CSF is the protein determination because the reference value for this is the total CSF protein are usually listed as 15 to 45 milligram per DL but are somewhat method dependent. And the higher values are found in infants and people over the age of 40 years old. So the clinical significance of these elevated protein values whereas abnormally low values are present when fluid is leaking from the CNS, and the causes of elevated CSF protein include damage to the blood-brain barrier, immunoglobulin production within the CNS, decreased normal protein clearance from the fluid, and the neural tissue degeneration. So the meningitis and hemorrhage condition that damage the blood-brain barrier are the most common causes of elevated CSF protein. So the elevated results, those are the meningitis, hemorrhage, primary CNS tumors, multiple sclerosis, Guillain-Barré syndromes, neurosyphilis, polyneuritis, myxedema, Cushing disease, connective tissue disease, polyneuritis, diabetes, and rheuma. And for the decreased results, those are the CSF leakage or trauma, crescent puncture, rapid CSF production, and water intoxication. So next would be methodology. So the two most commonly used technique for measuring total CSF protein use the principles of turbidity production or dye binding ability. So the turbidity method has been adapted to automated instrumentation in the form of nephelometry. So methods for measuring CSF proteins are available for the most automated chemistry analyzer. Next would be the protein fraction. So the protein fraction, the CSF over serum albumin index, is calculated after determining the concentration of the CSF albumin in milligrams per deciliter and the serum concentration in grams per deciliter. So the formula used is follows are the CSF over serum albumin index equals the CSF albumin milligram per deciliter over serum albumin grams per deciliter. So the calculation of an IgG index, which is actually a comparison of the CSF serum albumin index with the CSF or serum IgG index, compensate for any IgG entering in the CSF via the blood-brain barrier. It is performed by dividing the CSF over serum IgG index by the CSF serum over the albumin index as follow. So the formula of this would be the IgG index equals CSF IgG milligram per deciliter over serum IgG grams per deciliter over the CSF albumin over serum albumin grams per deciliter. So the normal IgG index value are vary slightly among laboratories. However, in general, values greater than 0.70 indicate IgG production within the CNS. Next would be the electrophoresis and immunophoretic techniques. So the primary purpose of performing the CSF protein electrophoresis is to detect the oligoclonal bands, which are may present in the inflammation within the CNS. So the disorders such as the leukemia, lymphoma, and the viral infections may produce serum banding, which can appear in the CSF as a result of blood-brain barrier leakage or traumatic introduction of blood into the CSF specimen. So banding represents both systemic and neurologic involvement as seen in the serum and CSF with HIV infection. So the other neurologic disorder including encephalitis, neurosyphilis, the Guillain-Barré syndromes, and the neoplastic disorder also produce oligoclonal banding that may not be present in the serum. So therefore, the presence of the oligoclonal banding must be considered in conjunction with clinical symptoms. Next would be the myelin basic protein. So the myelin basic protein or the MBP and the CSF may indicate or indicative of recent destruction of the myelin sheath that protects the axons of the neurons, which is the demyelination. So the course of multiple sclerosis can be monitored by measuring the amount of the MBP in the CSF. So the MBP may also provide a valuable measure of the effectiveness of current and future treatment. The immunoassay techniques are used for measurement. CSF glucose. The CSF glucose should be drawn about 2 hours before the spinal tap to allow the time for equilibration between the blood and the fluid. So ang CSF glucose is analyzed using the same procedures that was being employed for blood glucose. Specimen should be tested immediately because glycolysis occurs rapidly in CSF. Next would be the CSF lactate. The CSF lactate levels can be valuable aid in diagnosing and managing meningitis cases in bacterial, tubular, and fungal meningitis. So, the CSF lactate levels greater than 25 milligrams per deciliter occurs more consistently and that does decrease glucose and provides more reliable information when the initial diagnosis is difficult. CSF glutamine. So glutamine it is produced from ammonia and alpha ketoglutarate by the brain cells. So these processors to remove the toxic metabolic waste product ammonia from the CNS. Next would be the microbiology test. So these microbiology tests is to identify the causative agent of meningitis. So, ang culture medium that was being used, which are the microorganism must be recovered from the fluid for positive identification. And for the bacterial meningitis is for 24 hours, and for the tubular meningitis is 6 weeks. So, there are methods for preliminary diagnosis for gram stain. It detects the bacteria and fungal organism and performs a CSF from cases of meningitis. So note, all smears and cultures should be performed on concentrated specimen because they often only a few organisms are present at the onset of the disease. So the CSF is centrifuged at 1.5 grams for 15 minutes. And for the cytocentrifuge, which is highly concentrated specimen, 4 gram stain. And for the slide and cultures, it must be prepared for the sediment, and for the CSF and blood, it must be taken due to the present causative organism. So there are a list of organisms that was being found in the gram stain. Um, those are the Streptococcus pneumoniae or a gram-positive cocci, the Haemophilus influenzae, which is pleomorphic gram-negative rods, Escherichia coli, which is a gram-negative rods, and Neisseria meningitidis, which is a gram-negative cocci, and gram-positive cocci, which is the Streptococcus agalactiae, and the gram-positive rods Listeria monocytogenes, which is seen in newborns. So, the acid-fast stain or fluorescent antibody, which is not routinely performed on specimen unless tubular meningitis is suspected. So next would be the India ink preparation. So the India ink preparation, it detects the presence of thickly encapsulated Cryptococcus neoformans, which is an AIDS. So the Cryptococcus, which is seen more in gram stain more than India ink, because the Cryptococcus neoformans seen in latex agglutination tests than India ink. So next would be the latest agglutination and enzyme-linked immunosorbent assay, or the ELISA. So it gives rapid means for detecting and identifying microorganisms in CSF. So the kits are available to the following. To found the following, which are the Streptococcus group P and the Haemophilus influenzae type B. And next would be the Streptococcus pneumoniae. Next would be Neisseria meningitidis A, B, C, Y, and W135. Next would be the Mycobacterium tuberculosis and the Coccidioides immitis, and the E. coli K1 antigens and T. So, the bacterial antigen test or BAT, it is used in combination with result from the hematology and the clinical chemistry laboratory for diagnosing the meningitis. So, the Naegleria fowleri is it enters in the nasal passage and migrates along the olfactory nerves and invade the brain. So the motile tropocytes is in wet preparation of CSF, and for the non-motile tropocytes, which is cytocentrifuge stain smear, which are accompanied by increased white blood cells and no bacteria. Our last slide is the serology test. So it detects the presence of neurosyphilis. It is the use of penicillin in the early stage of syphilis that has reduced the numbers of neurosyphilis cases. So the procedure for this would be first is the Venereal Disease Research Laboratories or VDRL, which is preferred procedure to diagnose neurosyphilis. Next would be the next would be the fluorescent treponemal antibody absorption or the FTAABS, which is not sensitive test for syphilis. And next would be the rapid plasma reagent, which is not preferred, less sensitive than VDRL. So that's all. Thank you.